we're ready.
Great. Thank you for joining our workshop, Switching Frames, Reimagining Your Pediatric Practice Through Hope. I am Shirley Huang. I'm a pediatrician and Division Chief of Pediatric Primary Care here at Tufts Medical Center in Boston. And I'm joined by my colleague and presenting Dr. Hannum, who is a pediatrician in our practice, as well as the Pediatric Clerkship Director at Tufts University School of Medicine. We hope this workshop will be interactive, so please feel free to ask questions in either the Q&A or the chat throughout the presentation, as well as just putting in comments through the chat. And we'll be keeping an eye on the chat and Q&A so that we can interact more completely with you. It looks like there's about 15 people in the session now, and people may join along the way. So if we continue to be a small group, feel free to also just unmute yourself or show yourself on video, and we can call you out to ask questions along the way as well. We have three main objectives. The first is to identify components for a successful HOPE implementation. The second is to recognize how to effectively engage with all clinic team members during your HOPE implementation. And the third is to summarize methods to promote change when incorporating HOPE into your clinic. We realize that our clinic may be different from yours, and our presentation is really to highlight details of our journey from becoming a HOPE-inspired to a HOPE-informed practice, and to share some of our insights, our challenges, and our strategies to address those throughout our presentation. But before we get started, we wanted to just do some icebreakers, more so that we can understand who is participating in this workshop with us, and so that we can tailor some of the discussion to accommodate who is here with us today. So the first question is, what role do you have in the healthcare world? If you are in the healthcare world, and if you are not, welcome to our session as well. And where are you based? And if you want to just put your answers in chat, that will help us understand who is here with us today. Okay, it looks like we have another primary care provider from Michigan, and a physician, wonderful. A director of behavioral health services, wonderful. Great. And a pediatrician from Chile, wonderful. So we have a wide group coming in today. Our next question is going to be a poll of, are you thinking about implementing HOPE? Are you in the midst of your HOPE journey, or are you maintaining your HOPE-informed practice? And this is going to be a poll. If you switch over to polls, you should be able to vote for that. And I'll just give it a minute before we close the polls and see who's here with us today. Okay, so I think if we try to close the poll, we should be able to see the results of the poll. Great. So we have a mix of all three. Okay, so I'll try to sort of accommodate that as we move along. So just a little bit about why we decided to start our HOPE journey. We had heard about HOPE many years ago, but we didn't think about the start of our journey until about 2023. And it was after a period of many transitions for our clinic here. As was probably the case for all of you, in 2020, the onset of the pandemic created a sort of a domino effect of all the transitions that were happening in subsequent years, from how we decided to hold our practice, to how we transitioned to telehealth, to how we best supported our families throughout the pandemic. We immediately then went to a time period where we transitioned our electronic health record to Epic, which was a learning curve for all of us. And then we also had our clinic is based within a hospital setting. So we have the closure of our inpatient units and a lot of transitions with the specialists and even providers within our division in 2022. So it was really a lot of back-to-back transitions that were affecting us. At this time, what I really wanted was to create a purposeful framework to strengthen us moving forward. We had many team building events pre-pandemic, but nothing in the previous years to 2023. And we had wanted to kind of move forward from all of these different transitions that had been affecting us over the prior few years. And what we found was with hope was something that resonated with many of our already pre-existing values. And what we wanted to do was promote that within our team and really center around resiliency and building that resiliency within our team, and the way to also then build that with our families who continue to seek care with us here in our clinic. So how did we get started as a clinic? We put together a small work group to tackle the initial assessment and identify the priorities. This actually took us several weeks to kind of get through so that we could really look with a comprehensive lens at what our strengths were at the moment, and then areas that we thought we could improve upon so that we could identify what our priorities should be. We pulled together a small group of people to get different perspectives beyond myself and the practice manager. We also pulled together Dr. Hannum, who is involved with a lot of trainees that rotate through our clinic. We pulled together a social worker and nursing representation so that we could get varied viewpoints of what our strengths were, where everybody was thinking our priorities should be, and where we could focus on. We then planned an introductory meeting to launch Hope to the entire division. And this was by a Hope facilitator and involved a formal discussion and learning about Hope. It was not specific to what our clinic could or would do, and we did not even reveal our priorities at this time as to what we had decided with our small work group. What we quickly realized, which is part of what Hope is that, and I think this was just discussed at the keynote, was that there is universality, but not uniformity in kind of thinking about hope and how you approach hope, which is really wonderful in that it can be applied in multiple settings and across multiple roles. However, what we realized that it also led to different interpretations of what we were trying to accomplish, different levels of understanding of why and how we wanted to do it, and what we should be doing moving forward. And while it was wonderful to have this universality of being able to use these general concepts, we also realized that it was hard to get active engagement in building this framework that we wanted to really base our clinic on moving forward. So what we decided to do was to look for some quick and early wins while we regrouped and decided on how we were going to take a more purposeful approach into redefining the framework of what hope would be embedded within our clinic practice. So one thing that we did early on is we took some of the information from the Hope website, and we actually created our own building blocks worksheet. You can download this worksheet directly from the website. I know that there is a link down below where you can download it directly now if you would like. Otherwise, you can look on the Hope website, and this is readily available for whoever may want to access it and use it and adapt it. What we did is we took the 4 building blocks and we added 1 or 2 questions below each of them, and we started providing this to all our patients 6 and above for the annual well visit, so that as part of their initial sign-in, as they were getting roomed, they had the building blocks to think about and complete prior to us even going in and talking with them. And what we found is that this allowed us, one, to get used to ourselves the idea of the different building blocks and what could be below the building blocks, as well as introduce this idea of hope to the families and patients that seek their care within our clinic. And what this also allowed was some of the shifting of the framework in which we could identify and call out some pre-existing strengths, which in many ways, when you think about pediatric care, there's urgent care and sick visits and their well visits. We were using this for well visits, but for well visits, we're also asking about concerns. We're screening for social determinants of health. We're screening for developmental delays. We're screening for depression, anxiety. We're doing a lot of identification of problems, of things that we can work with the families to solve. But what this is truly looking at the positives. What don't I need to solve, but what may I need to call out as strengths to the families and amplify what may be already existing within their homes and environments. And in many ways, this allows us to shift some of the focus, not from what can I do to help you today, but like how can we partner and work together, and how can I help amplify some of the positive experiences that may already be there. And what I found in using this in practice is it also helped build the relationship and engagement with families in a different way. And I say families, but really it's with the children and adolescents who are filling out these forms. They could be drawing pictures, they could be writing in things that they don't necessarily bring up otherwise in the visit, but really helped strengthen some of our conversations and understanding of what's important to their lives. Some other quick and early wins that we worked through and worked on was just walking through our clinic. So, we wanted to support a positive experience and positive outcomes with families within their homes and communities, but we also wanted to be able to do that within our clinic as they walked in. And whereas we thought we were doing a really great job in promoting this positive environment, when we walked through, we found that it was not always the case. And we really wanted to lead by example so they would feel welcomed in our space, that they would feel engaged with us in many ways. And one example that I had as something that we thought we were doing a good job but didn't realize that we weren't, is that as we were walking through, as you walk into our clinic, with the pandemic, we had put up a sign on our front door that said stop, with a big stop sign. Don't walk in for a sick visit, please make an appointment. And we did that because we used to allow walk-ins, and we didn't want that with the pandemic, but we never took down the sign, and it wasn't a very welcoming sign. So, just going through our environment ourselves, we picked out things that we didn't realize were not welcoming until we took this other lens and sort of switching how we saw things. And what we did was we identified different team leaders within our team to help us through these different initiatives, of which we'll share many of them here. So one quick and early win was thinking about how we want to present ourselves to the patients and families that come through. And we partnered with a nonprofit, inner city nonprofit for teens. And if you want to click and learn more for Artists for Humanity, you can at the bottom there. But what Artists for Humanity is an inner city local teen nonprofit where they employ local teams to explore and express their creative abilities. And what we did was we worked with a wonderful group of teenagers who helped kind of put our vision into this mural here, where we are welcoming our families that come through our clinic. And the welcome is in multiple languages. These are the most common languages that we see for the patients that come to our clinic. And we have a nod to our floating hospital, which is back to our history of starting as a hospital on the Boston Harbor. So we have that in waves that can be turbulent at times, but we're on the upswing with the sun rising. And this is really how we wanted to portray our clinic to others. So this is just a representation of what we were hoping to kind of convey to the families that were coming in as a welcoming environment. On the opposite side, where I don't have a picture of, we also partnered with a local community cultural school, of which many of the students are patients of ours, but we have a rotating art exhibit where students have drawn pictures as part of their community engagement with their school, and then we have a rotating art display of those pictures within our clinic opposite this mural. So really what we wanted to do is reframe our own message to our patients of engaging them, having a welcoming environment, and really starting to delve into some of the relationships that we could strengthen with them. Like I had mentioned, we changed the way that we talked about sick visits versus walk-ins. That was one of our first changes. But we also went through all of our policies that we had posted in our clinic to really make sure that we changed them in a way that was more understanding and supportive of the families, and taking a positive lens to what we needed to convey, and a more collaborative view of how we would work together to work through some of the things that may come up. Now, we also took a time to pause, because what we realized right away was that even though the whole concepts seemed straightforward, we were making a lot of incorrect assumptions about what different team members took from the different concepts. People were aware of what hope was from the introductory talk and from us talking about it, but they had some limited awareness of why that was important to us. Why were we doing this as a clinic? And how could we do this as a clinic? And what is the role of each team member in making this happen? And what I really wanted to convey to the team was that everybody has an important role in this. It's not something that it's just the providers, it's the front desk, it's the medical assistants, it's the nurses. Everybody has an important role in really creating what we want to be as a hope informed practice. So a question that we had to really answer is, how do we increase staff awareness of hope and move forward from becoming hope inspired to hope informed in a way that, not that we wanted it to be uniform across all the different team roles, but we wanted everybody to really have a good understanding and a shared collective understanding of how we could work together as a team to address the different building blocks and to build these positive experiences and support that within the patients and families that walk through our doors. So we had to take different levels of understanding, different interpretations of what the building blocks were, and oftentimes kind of passive engagement to what we were trying to do, and really try to get active engagement from each and every team member across our team. And we decided to do this with QI and doing quality improvement. So as we began this journey to be a little bit more structured, we asked the question of our team members here after we had been in this journey for a few months: what are the 4 building blocks of hope? And we asked them, and this is actually in your poll. It's in your poll as sort of a multiple choice option if you want to click over the poll now. We asked them, what are the 4 building blocks? And we asked them in a way that we wanted to get the sense of if everybody could name them and understood what they were. So I'm going to give everybody just a few seconds to click on what they think the 4 building blocks are. And then we will close out the poll in a few seconds and just see. Okay, so let's close out the poll and see where we are. Okay, so we have a group of very engaged and knowledgeable participants, which is just wonderful. I will say that our team members could not state the 4 building blocks after us working through this for a while, and that made us really want to be a little bit more purposeful in what we were doing, because not only was hope to change the framework of how we practice, but we wanted to make sure that we would be then able to then project that to the patients and families who are coming through our clinic, and to support all 4 and not just one of these building blocks, but really to purposefully address all 4 of them. So then we decided, let's restart again and jumpstart what we need to do. And I'm going to share with you a worksheet that we put together. We're going to share it through a link that you can download there. And part of this is because we really do want this to be interactive, and we want you to think through some of the things that we thought about. You may have already thought through these things, but if you haven't, really just understanding that we want to work together and get feedback from you and learn from you too as we go through this. Sort of, what do you need to really make sure that you can have a successful implementation? So if you want to download the worksheet, you're welcome to go along and fill it out as we're working. We might have some time at the end to kind of circle back and fill out some of the things together. But just kind of to think about some of the things that we had to rethink about as we decided how to best implement it, and really make sure that we are anchoring every single team member in understanding how we can be a hope-informed practice. So going through some of these, which is right on your worksheet in the top section, who are your content experts? Do you need an official hope facilitator as part of your team? Who are you going to go to help really understand and help people understand what hope is and could be? Who are your local advocates across clinic roles? And we found that having some advocates across different roles was really important in engaging different team members and then thinking through what would work best. If you are planning to become hope informed, who do you need buy-in from? So we were very committed with our team, but we also wanted to make sure that greater leadership who had impact on our team were also informed about what the process we were going through. And what are other barriers that may exist to hope implementation? What may be conflicting priorities? How do you prioritize that and still move forward with hope? What clinic workflows or processes may be easiest to adapt to the hope framework? What are you already doing? All of us are probably already doing things that are very applicable to hope. So what can you easily do, and what are some quick wins that you can use? And what are the strengths of your clinic and setting? What are you already doing that you can amplify across all your different team members? So I'm going to turn it over to my colleague, Dr. Ham, to go over some of the work that we did on this front.
All right, thank you, Shirley. And so I'm going to walk us through with a pretty good level of detail how we operationalized really getting our clinic to be comfortable and familiar with hope as a framework, and then really trying to lean into this idea that hope is flexible, and how can we as a clinic model what hope is as we're teaching our patients and families about it, but again, really trying to build that ownership within our clinic itself, recognizing that everybody's way of interfacing with our patients and families is going to be a little bit different. And so we'll get into the details, and feel free to ask any questions in the chat along the way. So I want to kind of start off with the bottom part of this slide, which is that you do not need a formal QI project to build purposeful engagement. But we did find that approaching this with structure was going to both help us stay organized and also help us see what was working and what was not working. With I think any project, it does take a lot of time. And I think using the ideas about quality improvement can be quite useful, even though you may not be very structured in going through the process. We were able to recruit a eager first-year medical student, and this kind of coincidentally was timed at the end of the year for this student. Her name is Isabel Ball, and I want to give her a lot of credit for really taking the lead on this project and helping us with the implementation, because I don't think we would have been as successful in this project without her assistance. She did this as a summer project for us. So I think all of us may have learners who need scholarly projects, or who need or want to engage in research or QI or other things within the clinic setting. And this became a really good way for us to promote what we were hoping to do with hope, to give the student a great experience of building and running a QI project. And then again, kind of meeting our goals along the way and driving this forward. And her work from last year continues to drive forward what we will do today. And this is a little bit of an overwhelming slide, and I don't want to get into the nitty-gritty details about QI methodology, but I would recommend, if you're interested, using the Institute for Healthcare Improvement, the IHI, as a good model to really think about what can QI do for me as I'm going on this hope implementation journey. And again, whether you're using just part of it to think about hope and to understand the barriers with a little bit more nuance than maybe natural through discussion, I do think that there's some good lessons that we learned, and I'll walk you through our process. So this is a complicated diagram, somewhat purposefully, because it really shows the complexity of why we have this effect of really having a challenge of using hope, discussing hope, and again, fueled by this reframing that we were somewhat required to do when after our initial training, our faculty and staff just didn't really have the level of understanding that we wanted them to have to be able to push moving this forward. So this is what is called a cause and effect diagram, or a fishbone diagram. And it really helps think about the different buckets of people, environment, materials, methods, equipment, kind of the big things that may drive us to see that kind of downstream effect of really what we're not able to achieve. And this can systematically really help you understand, where are the places that we might have control and where might we not have control. As Shirley had said, some of the quick wins that we had implemented already show up on this. And so this can also help with some of the very informal things that you may be wanting to do within your clinic or setting that you're working in to really help move hope forward. And so as we were designing this project, we said, what, we don't need to focus on everything. That would be too overwhelming. And sometimes we can't focus on everything because things are out of our control to change. Knowing that we wanted to really model what hope could be through really demonstrating hope in our clinic, we really decided to focus on these kind of three buckets of intervention. The largest would be people. Knowing that, again, we have different people interfacing with our patients and families at different times, recognizing that knowledge, the culture, how we define or poorly define roles, depending on, again, what your role will be or the clinic workflow, how does that lead us to having this challenge of not knowing or not knowing how to talk about hope and to demonstrate that. And we had a good lens already about the materials and the methods of which we could kind of incorporate our project and use, again, what already existed or what we were already working on to really help move a lot of this forward. And so this was kind of how we started to prioritize our focus. As with any QI project, you should have an aim statement, which can really help you drive with the specificity that you need to say, here's really what I want to work on, and here is why. And it did take us quite a long time to work on what the best aim statement would be for this project. But we ultimately decided on that by December of 2024. And again, this kind of planning was roughly happening in June of 2024, that we want to increase staff and providers using hope building block behaviors greater than 80% of the time in their weekly opportunities. I would say this is a little bit of a complex aim statement. And largely, this is what we ended up using because of the complexity of trying to help people who are not patient-facing, so our administrative staff who are answering phones or helping with appointment schedulings or making referrals in the back office, to those at the front office checking patients in, handing out our developmental screens, to nurses who may only be coming in for a well-care visit to administer vaccines or in a sick visit to give medicine, or again, our clinicians really focusing outside of our learner space. So kind of focusing on our faculty of, where are they interfacing with students, or sorry, with patients and families, and what can they do? And so when we talk about the behaviors, we actually very closely defined what a behavior would be related to a building block. And I'll get more into that in a second, which is why this aim was a little bit non-ideal in some ways from the kind of purist mentality of QI, but really was as good as we can get because we wanted to stay flexible. And we didn't want to really isolate one group or prioritize one group. We really wanted to make everybody feel a part of this aim. Because the global aim at that point was to really establish our entire clinic as being hope informed. And so when you have an aim statement like this through a QI methodology, just for those that may not know, you will think about what are the drivers that are going to get me there. And so we thought of kind of four primary drivers, which would be knowledge of and proficiency of the HOPE framework, the resources that we have to address the building blocks, and that can expand into a lot of different places, what our workflows and infrastructures include through that lens of HOPE, and then generally our clinic environment. And typically with this driver diagram, you will then say, well, what are the drivers of those primary drivers? And this, again, will allow you to see with a lot more clarity when you really sit down and think about it, which is why we thought the structure was quite beneficial for us, to recognize where could we think about making change, how could we make change, and what logistically would be something that we say, we aren't actually going to focus on that because it is too complex. And so ultimately, we really focused on knowledge building and really keeping this provider, clinician, staff kind of centered. We very purposely said we were not going to actually talk to parents and families at this point because we really want to help build this model within our clinic of how we are conceptualizing hope so that we can send a uniform message in this kind of first phase of our own learning. So when it comes to the planning and kind of how we progressed along, I think it was very natural for us to use the building blocks as the theme of each PDSA cycle. And so our first was about relationships, which we did between July and August. Our second was about environment. And this really nicely correlated with the start of the school season in Massachusetts. So compared to other places, I know school can start anywhere from August through September. We tend to start right at the end of August or early September. And it made really natural discussions about school to be kind of our focus for that PDSA cycle. For October, we focused on engagements related to activities, a lot of fall activities at that time. Typically in New England is everyone's talking about it. And then really what hobbies bring engagement more specifically. And then lastly, partly because we felt this was the more challenging building block, we focused on emotional growth last. And really more specifically about how can we build and promote patient resilience and make sure that we talk about that in whatever role that we are able to. So this is an example of some of our data. And so these would be called run charts where you're really looking to how have we reached our aim. Really briefly, just to let you know about how our QI project was structured. Essentially, every week we would send our measure survey, which would ask in the opportunities that you had to do this behavior, which was really kind of crafted and formed around well care. Did you do the behavior that we talked about? And again, quite vague in the grand scheme of things. For relationships, it was very, very straightforward. We said we want to make sure that we can ask our patient parents, caregivers, those that are coming along with our families, what name would you prefer to be called? Really trying to build on that idea of strong relationships. See, personally, I call a lot of people mom and dad, even though I have really never asked them, is that okay for me to call you that? And so part of this was kind of through my own reflections with our student about maybe this actually is much more patient-centered for our staff to get their perspectives. This really helped us quickly look to the EMR as a tool that we could use. And unfortunately, we found that you can't actually really change parent names out of what is already logistically listed as the guarantor of their insurance. And so we have Epic, which has the sticky notes as a function where you can write essentially messages that everybody in your division or department is able to see. And so we chose that as a place to document that we had asked and what the parent preference would be. And I will say, a year later, roughly speaking, those still live in those sticky notes for the patients who were here during that change cycle. And so we essentially would ask people after the week, and when you had a patient that you were meeting that you did not know what their preference was, did you ask them their preference of what they wanted to be called? And so you can see here how we did not have as great of success as we might have wanted to. And there's a lot of kind of discussion that can happen about why some of these things didn't happen or were challenging to be sustainable. I think in this example, really the medical record not helping in the way that we had initially hoped was a big challenge for us. And again, lots of competing priorities in busy clinics, but at least we know through one of our balancing measures of are people feeling more confident about being able to promote this. And again, the confidence was already fairly high, and we did move the nail, so to speak, a little higher in terms of our ability to say that people are feeling confident or very confident in promoting strengths within the relationships building block. And so pretty much for every PDSA cycle that we had participated in, this is roughly what the data looked like. And to show you a little bit differently about a PDSA, which was a different frame shift, but more so to give you this idea of how do we incorporate other people. The environment PDSA, so PDSA number 2, to give you an example of administrators in the front desk, they're not going to be talking to patients and parents about, how is school going this year? but again, we wanted to build engagement, and this was the clever way that we came up with that. And so we were using a lot of stickers, which is always a great thing in a pediatric primary care clinic. And so as part of the front desk check-in, when these patients, again, 6 years and up, were presenting for well visits, they would get our building blocks worksheet, they would get our behavior developmental screen, and they would also get our Bright Futures handout that we give at all well visits. And they would now additionally get a sticker with the front desk asking, what is your favorite place at school? Really trying to, again, build those discussions and engagement. And sorry, I think my slideshow kind of came out of presenter view here. There we go. And when it comes to this engagement, was really a powerful way that the front was able to say, like, I feel like I am participating in hope. And that was something that we decided to carry through actually for all of our PDSAs, even though we weren't really specifically tracking that more readily. As I mentioned before with our PDSA, we really focused on, are you doing these behaviors that can drive the change we're looking for? And in what % of the time do you roughly think you did that? So for our administration and front desk staff, it was very specifically, this is your role. Give the sticker out and ask the question. Whereas for us in the clinic scenario, for me and Dr. Huang as clinicians, we would be talking about school. We would be asking this question, looking at the building block sheet. And so it became a way, again, to kind of have a unified thread within a building block related to behavior, but a little bit different depending on who you were and what your role was within the clinic setting. For staff, we were trying to focus more, again, often in well care. This may not happen where nursing is going to be coming in, but usually it would be within immunizations or just other times where they interface with them in the hallway. And they would be trying to highlight a positive or reframing if these answers were negative, if they were able to see the the worksheet. And again, the same thing happened with us. Is I think generally patients would be writing things that were positive. And so we had a little bit more of also kind of explaining why it's important to have these safe, supportive, nurturing environments for children. Again, really focusing on school because that was our theme for the environment PDSA. And so you can kind of see pretty easily, hopefully, how we are trying to kind of build multiple layers on what the building block could be and how can we extrapolate that to involve everybody in the clinic. So over time, this is what our overall run chart looked like. And you can kind of get a sense of where PDSAs started and may have ended. Unfortunately, we did not hit our goal, and that's okay. That is really what QI is all about. And I will get into a little bit more about some of those ideas in our next steps later. But this is generally the data that we had used to track. Again, are you doing the behavior that we are focusing on in this PDSA? We did also continue to ask questions about the other behaviors that people were doing. And there is a little bit more power that some of the behaviors were certainly sustained. And again, the best example is the front desk using the question and asking and engaging with our patients in the front, which they really enjoy doing. And so some of this is not captured on this run chart because of how our PDSAs switched frames in regards to the building block that we were using. But there was some sustainability of these behaviors, but we also identified a good amount of logistical challenges. So when we had finished this, again, this would be at the end of November of 2024, we did kind of a wrap up about our QI project, both sharing our experiences with all of our staff in one of our kind of all staff meetings, including the administration in the back, the front desk, MAs, social work, nursing, clinicians, et cetera. And we asked some very straightforward questions about sustainability and saying, are you doing some of these things that we had talked about? Are you using the first names of the parent and or the caregiver? Are you talking about school very particularly through what's positive in that environment? Are you engaging and asking about hobbies and activities in a somewhat similar way? And are you having discussions about building resilience and being resilient? And I think overall, a lot of people did find that those things were able to be sustained. This is where I would say we learned very easily through the QI project itself that weekly measure surveys were not always well answered. And so, there are limitations, I think, to using QI and trying to measure your success. But this made us feel a lot better, even though we really didn't completely hit our aim through our measures survey. And again, not surprising in some ways, given that we probably had about 50 to 60% participation pretty routinely through that. And so we then thought about like, well, what do we do now? And are there other things that you've actually also learned? And so one of the questions we asked was, do you have participation or did the participation in the QI project change your daily practice based off of those behaviors you were talking about? And I think we are really happy and proud to say that at least 75% of all people in our clinic across roles really did say that they had behavior change and they could feel it. And that's really the goal, excuse me, of QI, is to make sure that you can find a way to change behavior and really keep pushing that forward and keep it sustainable. And then probably the most important question would be, do you think that your patients, families, and children benefit from this project? And uniformly, everybody said yes. Unfortunately, this was a pretty brief kind of wrap-up survey, so we didn't have a lot more that we could kind of ask about, but we did know that this was impactful, was changing behaviors, and that our patients and families were benefiting from this. And so what came next is really a follow-up project. And this was, had looped in another student who was looking for a scholarly project, which is always easy to have learners help us out with pushing this data and moving things along. So I do recommend and want to put a plug in again for those who have other people interested in this, whether they are part of your staff, learners that come through, or other people that you're connected with, to really have an advocate or people that can help push these initiatives forward. And so we did a very small QI project follow-up, which is really through the lens of implementation science and what is going to be helping us become sustainable in whatever we do next. And so 3 key themes emerged from that. And these were kind of mini focus groups and kind of one-on-one discussions with multiple people throughout the roles in our clinic. So the 3 things we learned was to keep the interventions practical. So how easy is that behavior to accomplish? The best example would be, again, asking what preferred name you have. That is fairly easy. Talking about resilience, that may not come up as frequently. It may be hard, especially we tried to use vaccination as the frame. We were right in the thick of flu and COVID vaccinations. And so that is partly why that naturally made sense to us. But it was sometimes challenging to talk to a crying and upset 8-year-old about how they're going to be resilient and what they need to do. I think we still were able to do the message, but it may have been a lot harder to achieve. And we, through our measures survey and through QI, you should always understand how change is driving the process of other things. And so we did keep an eye on, was the request of the behavior you were doing leading to more time? And it thankfully did not. This was always less than 5 minutes of extra time that people had kind of stated that PDSA had led to. But I think important for people, as we ask them, like, what would be helpful, is to say, like, yes, it should be brief. It should be something that can be done pretty quickly through the workflows that we have. People really like the idea of focusing on relationship building, using the questions, using these conversations to build rapport with families and with children. And again, launching these opportunities to really talk to people when that may not have been the case otherwise. The best example, again, I'll give is our front desk staff, is they weren't really interfacing with patients as frequently as they were kind of pre-QI project to post, because they just weren't used to doing it. And so now we still will ask some questions, and hasn't been as straightforward or kind of happening all the time, but the front desk now feels much more engaged to be discussing things within the HOPE framework with our patients. And that really, again, kind of helps build these stronger relationships that we want to model. And I think the last piece about that relationship building is the content naturally does drive an improved understanding for us about family values and behaviors. And so it can lead to a better history for us as clinicians. It can lead to a little bit more nuanced understanding from our nurses and our other staff members. And the last theme from this kind of mini project was really that we should recognize and adapt to challenges. We made this QI project initially with a fairly concrete plan kind of through our planning period in the summertime. And we really tried to stick to it pretty closely, even though we weren't really getting as robust of improvements in our run charts. Again, we realized that the measure survey coming every week was potentially too much. We kind of said we want to still keep it going, But I think in the future, we need to really focus on like logistically what is easy, and are there ways to really think about this kind of least daunting task. Not everybody also checks their emails regularly. I know that I do because of just my roles in the clinic, but nursing may not actually check their emails as regularly when they're here because that's not really part of their clinical job. And so recognizing what logistics are leading to those challenges. And then for patients, is it really age appropriate? Our worksheet that Shirley had shown was really focused on younger age groups. We did give it to everybody, but I would say the completion rate for our preteens to teens and young adults was lower than it was for our school age kids. And how can we be mindful of that moving forward? And then lastly, the importance of clarifying, refining what we're doing, and really getting feedback often from our team members. We were doing that somewhat informally along the way, but we were really not adapting our project or our flow to kind of use what we might need to do to improve things. We didn't want to throw too many changes into the structure as well. And so we did not do that in the QI project. But we do now know, and in our next phases, really plan to be structured in getting that feedback and incorporating it as often as we can. And with promoting change, there's a couple of ways that we can think about promoting change with structure. And I just want to kind of put a highlight here that we decided to use QI methodology because it's something that I was generally familiar with and that most people in the medical world are familiar with. And again, whether that is super structured or not, I think the philosophies really helped us with our planning and understanding what we needed to focus on. These are just 4 other options of ways that you could engage in a very structured manner with those in your community, with your practice, with your workflows, to really help recognize what is it that really needs to happen. And so I think, Shirley, I'm turning it back over to you.
Great, thank you. And I wanted to just thank Chaz and Isabella medical student because this really helped us do some purposeful interventions that involved all our team members. A lot of what happens in hope, it happens naturally, but I think for us to really anchor our entire team in becoming a hope-informed practice, it was very important to make sure that each team member felt confident and competent to be able to understand and address, one, what the significance of the building blocks were, and also how they could make a difference and impact in discussing that and calling out different positive experiences within patients and families as they walked through our clinic doors. So one thing that we wanted to do is just have everybody answer in the chat this question. What do you like to talk about with your families that aligns with hope? What are you already doing? Because, many of these things somebody is already doing, and we were picking things to kind of amplify across different team members to make sure everybody kind of understood how they could be involved in the process. So what are some examples of things that you were already talking about with your families or patients that aligns with the hope concept that is already happening within the practices or communities that you're in? And I like that idea of the incidental bright spots. So calling out things that you notice that are happening in the visit and using that as something that you can bring attention to with the families of different positive experiences that are occurring within the visit. And delving more into like, what's your favorite part about school, and tell me about your friends. I think this is a great way to develop that relationship with your patients and their families, as well as getting them involved in discussing things that are working well in their lives and really trying to promote that piece of it. And asking what fun thing have you done, which is also a wonderful way of really developing that engagement piece of it, thinking about emotional strength and having that relationship there and how that has brought enjoyment in their lives as well. And from Dr. Sagi, how did you choose your child's name? Which I think oftentimes is a great way with the newborn visit. If it's a new family that you may or may not know, it doesn't even have to be a new family, but how did they choose the name? What were they thinking about? Strengthening those relationships, learning a little bit about the family, about the culture, really is eye-opening. Those are all really great. And then one thing that we wanted to kind of really call out, we decided to do a more formal QI project to really make sure that we were doing what we thought we were doing and how we could kind of pivot and change. A lot of what you need to do, you can do without structure. And really thinking about the 4 building blocks, like we did when we first started, it was just these quick and early wins and things that we could do. Look at your environment. How can you make your own environment where you provide care more hope informed? How can that be an environment that you can bring conversation and encourage families beyond your walls to have similar environments in their lives? How can you make your relationships with parents, caregivers, and patients more hope informed and strengthen those direct one-on-one relationships that you and every team member on your team has? How can you promote community engagement with parents, caregivers, and patients beyond the walls of the clinic? And how can you support emotional growth to your patients? One thing that I want to stress is that there are so many ideas that are free or minimal cost, and we had no budget to make this happen. So like everything that we did was sort of looking at our own resourcefulness and thinking about how we can make a difference with sort of what we have or what we can do to support our families. I think what I really liked from the keynote address, if any of you guys were there, was really thinking about what could be ordinary and take it to this extraordinary level. And that was a lot of what we kind of thought about of what are we doing? How can we make it better? How can we then make this in a way that we can then model and lead to families as to looking for positiveness within their own home and communities and within our clinic as a place for them. So, one thing that we did to kind of, which falls under, I think, the relationship block, is that we did our meet the team board in our waiting room. And what we wanted to stress was that, maybe you can recall who your pediatrician is, or maybe maybe not, who that person is behind the name. But beyond each and every one of us, there's a whole team that supports them. And there are times where I know the patient doesn't want to see me. They came in because they want to talk to my community health worker or my social worker or a different team member, and they're interacting with different team members. So we wanted to make sure that we included every single team member in our group in the waiting room so parents could identify and put a face to the name if they often would. Sometimes they have phone relationships with these people, but really to really support this relationship building of each and every team member to the patient and family that's coming through to our clinic. The other thing that we did that actually we had many champions within our clinic who were really invested in putting this together and actually sustaining it is we created a community resource corner within our clinic where we accept donations for a variety of items, clothing, shoes, personal hygiene items. We have a shelf for food, books. Depending on the season, we might have some winter jackets, Halloween costumes, whatnot. But this corner is really part of our clinic, and it's for our families that come through here or anybody who wants to take from the corner. There's no restrictions of who can take and how much they can take. It is there for anybody to take. What I found out a few months after we had actually started this from our front desk staff member who helps to kind of keep things tidy and restock throughout the day is that actually some families just come in the evenings without a clinic appointment, and they just come into our clinic and they take resources and they talk to the front desk and they leave, and I didn't actually realize that was happening. I just assumed people who were here for their appointments would come and take as they went. But actually many of our families have utilized our resource corner as part of their community of where they can feel supported. And this is one step beyond sort of just us screening for social determinants of health, and it is no way related to our screening, but just a resource that we have available, all from donated items for our families who are part of our community. Another team member championed putting together and developing some crossword puzzles. So as a way to engage our different children and adolescents in our clinic, there are different age groups that we had tailored these for while they were waiting or while they were around, just to bring in a little bit more about the different blocks. There's crosswords for each of the blocks and develop some conversation for each of the blocks based on the words. This is kind of a summary of some of the things that we did overall. And, some of this is just a sharing of ideas, and none of these things actually cost any additional, required any additional resources, but just really kind of getting ideas from the group and putting things together. So we went through this hope journey together as a team because we really wanted this to be the framework for our clinic. It's part of the onboarding of any new team member that they get an introductory video about hope and an opportunity to ask some of the things that we're doing and calling out some of the things that we are doing. It's a standing agenda item. We have quarterly all staff meetings where we go over a variety of different things, but hope is always a standing agenda item where we review things that we've done since our last quarterly meeting. We get feedback from the group, and most of our great ideas have come from the group of brainstorming sessions. We do some sort of instructional topics in teaching as well. So it's something that we've incorporated to our regular practice. We have a community resource corner, like I just showed you. We have the building block handouts that we give for 6 and above. We have the waiting room questions of the week, which we have continued to do even beyond our QI work. We have the word searches. We have started using and utilizing the Mount Sinai parenting tip as a way for us to start the discussion for those younger than the 6 years that we use their building block handout. And this is an example of using some similar resources that are available already and not trying to create everything from scratch. We found that we had a hard time kind of thinking of new things to talk about each and every week and month. So we've actually been borrowing from the Mount Sinai parenting tip topics that are applicable and adjacent and resonate with the idea of hope, and using that in our daily huddle as a reminder to everybody that maybe for this next 2 weeks, let's focus on this specific item of resiliency and promoting that with our families with the younger age groups. And we know that the younger age groups is really where you start with the early relationship building. So like making sure that we emphasize that from the get-go. We have other ideas that are kind of in the works, or more some of these ideas that are sort of in a way moving forward. We are talking about getting badge reels, which I mean is what holds our IDs up so that we have sort of a talking point for families to ask questions, even if it's what is that or what is hope, so that we can start that conversation and really talk to them about what we're doing here as a clinic. Emotional growth was what we found the hardest for different team members to really wrap their heads around, and how to purposely address that building block. So we tapped into a few different team members and voted on what might be some common emojis that would be familiar to our patient panel and population here, and picked out a few that we ended up posting in our waiting rooms, similar in many ways to the pain scale, but not having it necessarily be one right or wrong answer, but just like, where are you today? And then starting the conversation with that and talking about resiliency in regards to building emotional strength. We are in the process of working with our learners and thinking about more QI and how we can structure that moving forward in a different project. Like I said, we're trying to expand to our younger age group, so really to promote that early relational health and focusing early on how we can help support our families. We are also in the process of re-looking at our worksheets and question boards and making sure that we are asking new questions. It's been about a year since we started with that, so everybody who came in for annual physical is coming in for another annual physical. We want to make sure that we have similar themes but different questions to start to kind of promote some of the discussion with our patients. And then we are thinking about how we can better incorporate parent, caregiver, patient voices in what we do as we continue on this hope journey. And this, because it is part of the framework of what we do, we have really wanted to shift the perspective of how we practice, and we think of this as an ongoing journey. So even though we are now hope informed, we are still thoughtfully and purposefully thinking of ways that we can continue to make sure that we are purposefully making changes that will positively impact those patients and families that choose to come to our practice here. So I'm looking at the chat and the Q&A to see if there are any questions, which I do not see currently. What we thought we would do next, and I think we have about 30 minutes left in the session, was to break into the breakout groups so that we can have more interactive discussions. What we can do is we can have 2 breakout groups or 2 breakout rooms. And in those breakout rooms, we'll have time to kind of collectively share ideas, because I think we have a lot of good ideas amongst all of us, and thinking about working through either some of those worksheets or things that may have arisen as we were presenting. And then we'll regroup 10 minutes left so that we can share some of those discussions with the rest of the group.
We're back.
I think we're back. And what we wanted to do is kind of regroup in our last few minutes together some of the discussions that happened in the 2 different breakout rooms, so we can kind of share some of our shared learning. In our breakout room, we nominated, or Karen very kindly volunteered herself to summarize what we discussed in our breakout room. Karen, I don't know if you can unmute. You're still okay. Perfect.
Hi, Jess. In our group, I was inspired and in awe of the way that people are taking these ideas and bringing them into their communities. And I was particularly interested in efforts to change the culture, and we agreed that changing culture is not easy, particularly medical culture, but we all felt pretty hopeful, I think, at the end that what this is doing matters, and bringing that into the community will have ripple effects that maybe we won't be able to measure, but are self-propagating because they feel good and they feel right. And that was my takeaway.
Thank you, Karen.
Yeah, thank you. I think that's such a good point, Karen, that, this just how you feel is, and how that changes is palpable. And I think even if it may not come out of like, here's exactly why, this question or this kind of content is important. I think, just the feeling that we get of knowing why we're saying things, and especially in a really chaotic visit, and being able to kind of prioritize, like, if there's one thing that you're going to hear through this chaotic toddler well visit, like, here it is, and making sure that you can kind of amplify that through, again, what we're kind of already doing. And I think that is such a good point, that it feels really good to know that we're focusing on this kind of positive frame, and trying to highlight those positive experiences that we know happen, right? And they're happening everywhere. It's just that we really need to shift that attention and move away from and kind of that negative frame to say, indeed, like, you have done this before, and you can, and I believe in you. And I think, one thing that I have found myself kind of saying a little more frequently just through this process, not part of, again, our structured study, is, when I'm talking with toddlers or their parents rather, and caregivers about the challenges of toilet training or getting them to sleep well or working through picky eating is, like, you've gotten this far. Like, I'm proud of you for that. And I think that goes a long way. I mean, we were having a discussion recently about just like the stress. Parenting is a extremely stressful endeavor, I think, in the United States these days, especially with misinformation and kind of how we can, organize that. And I was having a conversation last night. I sit on the section on early career physicians at the AAP's executive committee, and we were hearing from the policymakers, and it was like, how do we work against all of the misinformation that is out there? And I think, people really want to know how they can do things right, for their child. And I think that's where framing it in this positive way is really how we can get our voices amplified in a very kind of misinformed, chaotic media environment. And I think the message there that is probably worth sharing briefly is that people may not be looking for misinformation or be looking for the negative things that are really in our faces, but digital media puts it there. And so it can be our job to, again, kind of shift that frame back to the positive lens and say, like, you know what, even though you're worried about this, I'm glad you're worried about it because it shows that you love your child. That's building a strong relationship. And here's what we can do, to kind of build your own resilience through, these parenting struggles. And I think that, there's a lot of power there, a lot of practical barriers, though, to being able to feel comfortable doing that in the moment. And I'll kind of add just a little bit what my group had said, which was, kind of like, how do you find the time through like 5 developmental behavioral health or mental health screens and like thinking about all of these things. Again, I talked about us using the Survey of Wellbeing of Young Children, the SWIC, as our developmental screen, which was developed here actually at Tufts Medical Center, ironically. But I would say maybe not coincidentally per se. And I think the love of the SWIC that I have, the last question is, how often do you read to your child? And, I was talking about kind of our next steps is how do we engage learners? And, we were thinking reach out and read makes the most sense. We're already giving books. It's already there as a tool. We really should be doing it. It may be lost in that kind of negative challenges areas. And so really thinking like, can we use our learners to amplify that message, knowing that it is reinforced on the screen? It's something that's already, part of that well care. And again, like trying to find those intersections of what is already happening or what will need to happen. And how can we just subtly ask the question differently? And I think the last thing I'll say is Megan and Sandy are here together with a large group. And I think, getting that kind of large lens across sectors is really an important, powerful voice, especially knowing like, where do I start? It can be daunting and intimidating. And I think we kind of talked about how that can be very important to hear those perspectives. Because again, we know we made some assumptions about what people might already know or what they had learned, and it was definitely not true. And I think, hearing from everybody and hearing those voices, even if you have a diverse group of local advocates, you still really need to kind of connect with everybody as best as you can. And I'll stop there because I know I like to talk.
Yeah, well, I do too. And I'll leave you with 2 quotes. One is by one of my heroes, Bob Hannum, a pediatrician who recently passed away, and said, if you only have 10 minutes, make it the best 10 minutes of that family's day. And the last quote is by Maya Angelou, who said, people won't remember what you said, but they'll remember how you made them feel. And I think we can definitely work with that.
Thanks, Karen. Yeah, those are great quotes.
And thank you, everybody, for joining us this afternoon.
Yeah, thank you, and enjoy the rest of your time.
Thank you. Nice seeing you.
Thank you so much.
Bye.